Our topic today is going to be digestive healthcare organization in the post-pandemic era. So we want to focus not only on the challenges, but the things that we would have to adapt because of this pandemic that we've lived, but also on the opportunities, meaning that there might be probably a better way to do things. We might get more efficient in some things and eventually more productive. So we want to touch on that. So it's going to be a very interesting webinar looking at the future, which is also a little bit difficult, but we have two great experts to take care of that. I want to thank you everybody for joining. We know that today's July 15th, so it's in the middle of vacations for many of you, and also some of us are looking for vacations also. So we really appreciate that you took the time to join us today. And I would especially like to thank our experts today. It's our fortune to have two great European experts in the field of gastroenterology with vast experience in many fields in our area. So with us today is Professor Heinz Hammer from University of Graz in Austria. Hi, Heinz, welcome.
Hi, everybody. Hi.
And Professor Giovanni Barbara from the University of Bologna, Italy. How are you, Giovanni? Welcome.
I'm fine, thank you.
Perfect. I wanted to tell you that we have been touching on several topics, single topics on how COVID impacted gastroenterology and hepatology and endoscopy before. So I would encourage you to take that in advance, because some of the issues are going to be addressed here today. But this one is, like I said, a bit special because we want to look into the future, see how things have impacted our clinics and how we can do better in the future. We know that COVID-19 has changed society completely, and that has had a really great impact on healthcare employees, on patients, and in the way we deliver care. So that's going to be our focus tonight. And lastly, I wanted to say that we know that we call the webinar post-pandemic, but we know that the pandemic is probably not over. We are seeing flares all over Europe, and we have some data, for example, recently from Spain, published in Lancet last week, talking about a seroprevalence of 5%. So only 5% in the Spanish population are infected, have been infected with the virus. And we have similar data from other places in Europe and prevalences of, for example, 7% in the States. So there's still a lot ahead of us, and we are very much looking forward to address those issues. These are our disclosures, nothing to declare. And this is the structure of the webinar. We're going to touch on 4 main areas. The first will be organization of patient care. I mean, how we organize our units, and how the COVID has impacted teaching and ways that we can still provide a very good teaching. These 2 issues are going to be covered by Professor Hammer. And potential shifts in clinical presentations and the consequences of shifting the resources to COVID patients, and also the impact on this pandemic on research. And Professor Barbara is going to take care of that part. The structure of the webinar is going to be quite interactive, or that's what we want. Every part of the topic will start with some questions to the audience. I would encourage you to vote. Please vote quickly so we can move on. So it's important for us to know how this pandemic has impacted you, so we can direct the discussion following that. There will be some personal experience and some review of the evidence by the experts, and then some recommended literature. So please feel free to ask any questions on the chat. We will try to address it. It's a lot of area to cover, but we will do our best to cover the areas that have more interest for you. So we have sunny day. We have like 58 participants right now, 2 great experts, exciting topic. So without further ado, Heinz, the floor is yours, the virtual floor.
Thank you, Ignacio, and heartful welcome to everybody out there in the European airspace and beyond. I want to use this excellent opportunity of a webinar for a specialized approach to teaching. Please be reminded that this webinar will be online for you to watch and to review with all the contents we will present here in a week's time. So how I take advantage of this is to focus on some special things which need some explanation, but I also have included some summary slides, which I will bring up just shortly here on the screen. I do not read all the text which will be on the screen, because you can review, we can save time, and you can review this text later on at your own pace, at your own time of choosing. Now, as Ignacio said, we are starting out with questions. And these questions, these first 5 questions, relate to the organization of patient care, and we ask for agree or disagree questions. Please bring up the first question for voting. This is: written instructions were available on how to use personal safety protective equipment. Do you agree or disagree? Okay, this was a very quick voting, a very fast voting with 100% agreement. Very good. Second question, please. There was enough personal safety equipment available. Do you agree? Do you disagree? Well, yeah, please come on and vote. You see it online, how it develops. And the UEG office will decide when to close the voting. They see the numbers of voting coming in. So it's a very interesting distribution. There are still some votes coming in, and the results changing to approximately, as it is now, 50-50 in your experience. I think we can continue to vote number 3, question number 3, which is: patients wanting to enter the clinic or the ward were screened for symptoms. What is the situation in your area? Agree or disagree? 39 votes now. These results are based on 39 votes. I see the number of votes having been given. 41 votes now. We have 70 people now attending the meeting. There could be some more people voting, but we can close the voting right here and go to question number 4. Are also patients allowed to access your ward or your clinic without result of a COVID test? Yes, please keep voting on that, whether you agree or disagree with the statements. We have 36 votes now on that. Yeah. I think we'll stop it right here with about 40% to 60% distribution to this answer. And now question 5 about written instructions on patient care priorities. Were there written instructions on how to select patients for canceling appointments and how to create waiting lists for you to decide on which patients to cancel, which to put, whom to put on waiting lists, how to bring in patients from the waiting lists? So again, with 37 votes, 38 votes now casted, this comes around to a 50-50 distribution. That's very interesting. Now, I will continue with my presentation and go to this, to my personal experience. I want to bring up the following points. The patient care during the COVID lockdown and thereafter, protecting healthcare. These are the focuses we have to consider: protection of healthcare practitioners and patients, identifying and separating patients at risk, providing sufficient capacities, not forgetting the non-COVID patients because they are still out there. And especially in my case, which I'm heavily involved in students teaching in my university, it's also virtualizing student teaching, that is e-learning. So, to give you a background information on the COVID situation in Austria, and these are official data from the Austrian government, and you see here on the line the dates we had the sharp increase in COVID cases beginning mid of March, where we had this lockdown period. And the decrease in the cases, these are the daily number of new cases of COVID. And we survived the lockdown phase. And we are now increasing again a little bit with number of newly developed cases to approximately 100 cases per day. Now, this was the time when we got the notice that our hospital and our ward, the gastroenterology ward, would become a COVID dedicated care facility. And in order to become, and we had about a week advance in notice, which gave us time to plan for the whole hospital, the Department of Internal Medicine, and for our division of gastroenterology and hepatology, with the main goals of separating patients and keeping patients and caregivers safe. Now, this is a graph from our planning and our solution to this. We separated patients who attended the emergency clinic into a COVID emergency clinic, which patients were sent to when they had the likelihood of having COVID.
Maybe we can make some comments on the questions that Heinz posed to the audience. I think that these are very interesting issues. For example, regarding the availability of PPE in different countries. I think that that was a big problem, at least in some regions of Europe, particularly in Italy, because when we got the infection coming in and dramatically increasing in the first weeks at the beginning of the year, we were totally unprepared to this infection. And so immediately we had to face the problem of lack of PPEs in most of the wards, particularly in northern Italy, because northern Italy was severely affected by the infection, particularly the region of Lombardia, which is the region of Milan. And that was a dramatic problem because at the beginning, the healthcare providers had to visit the patients without proper PPEs. So that was a problem. Then with the time passing, we resolved that problem. And I think that probably the fact that the infection reached us in that moment when we were totally unaware of what was going on was a big problem. So that was a major issue in Italy.
Right. I'm aware that it was the same problem in many parts of Spain, especially
Spain as well. Yes,
especially in April. It was really difficult to get the material, and we had really problems with that. Is that problem solved right now, Giovanni? Do you have FFP masks and enough material in all Italy, or is it still a problem?
Yes, no, that resolved quite quickly after a month or so, and then we received all the PPEs that we needed. But at the beginning, I remember, and as a matter of fact, you have seen the news, many physicians and healthcare providers got infected, and that was a big problem, particularly in the region around Milan, Bergamo, and also in Veneto. So that was really a problem. And I remember that also in Spain was a problem at the beginning. Yeah. Probably the other countries that got the infection after a while could prepare themselves to the wave of COVID-19 coming in. So that was a big issue.
There were also some questions about testing, Giovanni. So I think it will be interesting because I think one of the things we have here, let's hope that Heinz is soon with us, but I think it's good that we have two different scenarios, both Austria and Italy, that were impacted very differently. I'm working in Norway now, and the impact here has been very, very reduced if you compare with Spain, for example. So do you have any policy for testing now for people coming for elective procedures? And what's the criteria you use to choose who to test that comes to the hospital?
Yeah, well, we faced different phases during the infection. At the beginning, many wards were converted into COVID wards, and all the patients were tested with swabs. And then we faced the second phase where we had three different type of wards in the hospital: one COVID positive, one suspects, that were all the patients that were coming in with fever, cough, and other symptoms. And then we had the clean wards. And for all the patients that were coming in the hospital, they were tested with the swab. And then we developed, as the number of infection decreased, an algorithm that was classifying the patients in high risk and lower risk. The higher risk were going to the suspect ward, where the patients were tested several times, at least 2 or 3 times with the swabs.
Yeah.
And if they were positive, they were going to the COVID positive ward. If they were negative, they were going to the clean wards. So we had 3 levels in this case. So I think that at least in my hospital, which is one of the largest hospital in northern Italy, we absorbed very well this wave of patients coming in. But I know that in other regions in Italy, it was a little bit more problematic, particularly in Milan, and where they had a huge number of patients coming in, and they had also to transfer patients to other hospitals because they couldn't get all the patients in the hospital. So now we have this algorithm that is subdividing the patients in high risk, and they go to the suspect; low risk, they go to the clean wards.
Right. That's more or less what we're doing here.
Yeah. So screening is very important. Still, we do not rely entirely on the tests, on the swabs, because some patients, and I think that we derived this way of working from the Chinese experience. Some patients are diagnosed as COVID positive, even if the swab is negative, but the clinical and radiological picture is suspect enough to classify them as COVID positive.
Right.
So we know that the positivity of the swabs is not very, very reliable. There are patients that have negative swabs even if they are infected. So we do not rely entirely on the swabs, but also on the laboratory, the radiology, the clinical picture, and so on.
Right. Can you test as much as you want? I mean, do you have availability of tests the way as many as you can you need to use, or you need to make some very selection for those who are, for example, contacts and people with symptoms, or people coming from endemic areas, or that?
Now we have enough tests, we have enough reagents to do all the swabs we want. So we are in a safe position now, but at the beginning it was a little bit problematic.
This was the situation on the ward with the COVID positive patients, the unresolved patients where the test still was open, and the green patients with a negative COVID test and being transferred to other non-COVID wards or discharged to other hospitals. So we had to redesign our hospital unit with the 4 bedrooms, the 2 bedrooms, and the 1 bedroom. and designed where we put the personal protective equipment, the patient documents, and the disinfectant outside of the table, and the table for discharge of personal protective equipment and disinfection in the inside of the room. For endoscopy patients, we had I looked up the numbers of endoscopies performed in January to July 2019 and 2020, and we saw a decrease in most of the procedures, an increase in ERCPs and endoscopic ultrasound. For the endoscopies, we wanted to follow our general rule we had in the hospital to separate patient flows so that COVID positive and COVID negative patients would not cross. So we designed 4 different areas where endoscopies would be performed, depending on whether patients were infectious or potentially infectious or non-infectious, and on their cardiorespiratory stability, as well as the current patient location, whether they were in the COVID ER, in the non-COVID ER, in the patient ward, the non-COVID ward, or in the medical ICU. Shall we come to the question number 6? Before the COVID epidemic, I had used virtual clinics, please answer, for up to 10%, for 10 to 25%, or for more than 25% of patients. Before the COVID epidemic, how much virtual clinics have you used for how many of your patients? Up to 10% is until now the current favorite. Some have used it for like a little bit smaller than 10%, have used it for more than 25%. Okay, you can still, this is the final result of this answer, and let's go to question number 7. During the COVID epidemic, have you decreased patient contact? I have decreased patient contact by up to 25%, 25 to 50, or more than 50%. Your special. This comes up quite evenly distributed. Please, this is designated as the result. Please bring up question number 8. During the COVID epidemic, I have increased the use of virtual clinics. Agree or disagree? Okay, this is the final result. 3/4 have increased the use of virtual clinic. And now question number 9. During the COVID epidemic, I have used virtual clinic for up to 10%, 10 to 25%, 25 to 50, or more than 50% of patient contacts. This also evenly distributes with a focus on for up to 10 to 25% of patients, and again for more than 50% of patients. Now, for the task of keeping track of patients, we designed a Excel sheet where we categorized patients: category 1, category 2, category 3, and special like polyposis clinic. Category 1, as an example, would be shown here. What would be category 1, what would be category 2, or category 3. We had the name of the patients, the endoscopy, or the thing which needed to be done, and the result. We first took this list and kept track by color coding, with coding green, which at this point of time was already completed. They were cancelled and already called in, with color coding of red, which still needed to be scheduled, or blue with a new appointment to be scheduled. So this is the challenge of keeping track of these patients and not losing anyone who had been cancelled. And we in the hospital were supported by the public, by the hospital regulatory authorities. by providing information in local newspapers. Now this was much of personal experience. If you look at the PubMed results, and for example, look for organization patient care in COVID times, then 696 results pop up. And if you look at virtual and patient and COVID, then 165 results come up. Now, these are the summary slides which I had mentioned before, which I will not go through in detail, but you can read that up later. Summary on inpatient wards, on outpatient clinics. Also, you may read this up at a later point at your leisure times. Endoscopy suites. And the summary slide on my personal experience in the COVID lockdown and now in the hospital with dedicated areas for the care for emergency admissions, scheduled patients, endoscopy, ultrasound, and so on, as we are doing it right now, for you to read up on that. I want to point out this nice paper from a Spanish group, which is again a very good reference, which describes how to resume activity in gastroenterology departments. So I very intensely can recommend that to you. And finally, this is a list of recommended literature. Out of these several hundred of literature, I have chosen a few of them. They may not be the best. There may be others who may serve you better, but this is my suggestion for this. Let's go to the point of teaching, and we again start with question. Question number 10. Number of interventions and procedures for GI and hepatology trainees. We are now talking about trainees. They had the usual numbers or less, up to 25%, 25, 50, or 50% less. We do not see the dark blue color here, so none of the respondents until now says that it was usual numbers. There was a decline, which was different, however, in size and effect, with 44% as currently for more than 50% decrease in numbers. Still questions coming in, otherwise we can close this. Okay, let's bring up question number 11. Number of clinical teaching and patient rounds for students. Now we are talking about students. The usual number or less, 25%, 25 to 50, or more than 50% less clinical teaching and patient rounds for students. And again, okay, in some areas from our respondents, there was the usual number, but in many, the numbers decreased. You still have the chance to do the voting. Okay, this is the result. And now coming to question number 12, replacement of gastroenterology, hepatology or surgery lecture hall teaching by web-based teaching, and up to 25%, 25 to 50, or more than 50% were replaced. That is the total shutdown of the universities. So in most of student teaching was heavily, lecture hall teaching was heavily affected, as it looks like, but you still can give your votes. More than 50% of lecture hall teaching was replaced by web-based teaching. Thank you for your input to that. Now let's go back to my slides, and the first one would be again an information on PubMed results. If teaching and COVID gives you more than 2,000 results. I want to pick out from that one paper which gives two very interesting aspects on GI and hepatology trainees, comparing the 30-day period before and during COVID pandemic. And this shows that numbers of different procedures significantly decreased from 3 to post the COVID period. In this study, students trainees were also asked for their concerns, and 80% were concerned with acquiring COVID-19, either extremely concerned, moderately concerned, or slightly concerned. 72% were concerned with prolonging training, and 90% with competency acquisition. Now, these are the challenges. You can read that up at a later point. And this is my personal experience with the impact on student teaching in our hospital. We had a shutdown, we had delays in exams and graduation, and we had a focus on e-learning, which functioned in approximately 60% of lectures in the total university. For the fall 2020, the situation is yet unclear. However, it gets increasing notifications that we still may have a university lockdown, a shutdown of lecture hall teaching, also in the upcoming fall. For teaching, I choose this literature, which was a national survey of final year medical students. You can look it up, how COVID has impacted on examinations and placements in British medical students, and how these British medical students feel about being asked to assist or start working in hospitals ahead of schedule. And that's also a study worth looking at. Here is a summary of challenges in student teaching. You can look at that at a later point of time, and recommended literature, which completes my part of the presentation. I'm sorry that there was a problem with the technique, and that due to that there was a little time delay. Now I think Giovanni will take over.
Yeah. Thank you very much, Hans, for doing it as quickly as you could. You gave really interesting information, and again, we apologize for the inconvenience, but that's life, and that's what happens, and it's the technology, so that's perfectly okay. So thank you very much. Giovanni, do you have any comments on teaching? How it has impacted your practice?
Yes, regarding teaching, also in Italy, and particularly at our university in Bologna, we had a huge impact of COVID-19 on teaching. Everything was shifted towards, web-based teaching, graduations, exams, everything virtual. And I think that we took advantage of technology. We started to learn a lot on how to manage this situation via technology. And I think that in a way there are advantages, because we have to move less, but also disadvantages, because not seeing face to face our students, not interacting with them, and not getting the questions in the rooms is a different way of teaching. And I think that we lose a lot with that. But we had to face the situation. There has been a lot of discussion at our university on how and when to restart seeing our patients in the rooms, in the lecture rooms, and we think that we are not prepared for the fall. And we will see whether we will start again face-to-face teaching starting from the beginning of next year.
Right. I can tell you from the experience in Norway, in my university, it looks like things are going to start in person. So the regular classes are starting now at the end of August. So that's the message we got. So it looks like it's going to start again as usual. So let's see how it goes. There will be probably some things to implement in the labs and other things. Before you go to your part, I would like to please encourage the viewers to make questions. You can write them in the chat so we can have things to discuss in between, and also after we will try to leave a part for discussions. It would be very interesting if you could pose questions or even make comments on your personal experience on the things that we are addressing. The other thing is I forgot to present myself. I'm Ignacio Catalan. I work in Norway, and I'm a gastroenterologist, and I work in the Norwegian University of Science and Technology in Trondheim and in the Levanger Hospital. And yeah, please go on, Giovanni. I think we have less time. I think we probably be able to take 5 or 10 minutes over time, if that's okay with you, because we would like to hear from the audience as well. So please, Giovanni.
Yeah, I agree with you, Ignacio, that it's very important to get the feedback from the audience because the situation in Europe is so heterogeneous that everybody has to tell us how the situation in their country is. So, you know the format. We're going to start with the questions. If I can ask to pull up the question number 13. You might see some repetitions here, but I think that it's important to see how the situation here is. Number 13 is the type of patient that I've seen has changed substantially during the COVID-19 period. And you see that again, wait a moment to get the answers. But you see again that the situation is quite heterogeneous in Europe. Some regions of Europe probably didn't see many COVID-19 patients. So here are the results. You see that in some countries probably there were no major changes. Next is question number 14. That is, if we can pull it up, okay. Only severe cases, urgent cases, oncology patients were admitted to my division. This was the case for our ward because it was converted entirely to a COVID ward. So we had no chance to see regular patients and we had to change entirely our practice. So again, you see that the situation in Europe is heterogeneous. In some countries, probably they continued their regular practice. Next is question 15. Endoscopy procedures. This has been already discussed in the previous presentation by Heinz. Were reduced by more than 50% in my department. Yes, here is the answer, 87%, more than 50% reduction. Next is similar, but now related to ultrasound procedures. Ultrasound procedures were reduced more than 50% in my department. Let's see, we wait a few moments to see the results. Probably a little bit less, so it was thought that ultrasound was less at risk of infection of the healthcare providers, so probably this continued a little bit more compared to endoscopy. Next is question 17. I feel that COVID-19 will have a negative impact on patients' GI disease. This is very important. And a few moments to see the answer. And I think that many of you think that there will be a negative impact on our patients. 84% think in this way. Next, witness a rise in GI cancers. This is an important question due to COVID-19. Very important because we reduced the rate of our screenings, follow-up of polyps, for example, surgeries for our patients were delayed. Around 66% think that COVID-19 will increase cancers in the future. This is very important and worries us a little bit. Next is question 19, the last for this part. Stress related to COVID-19 infection will have a long-term impact on certain GI diseases. This is interesting, and we will show you some hypotheses and some results on this. Yes, many of you, around 90%, think that there will be an impact of this tsunami that we have to face with COVID-19 on the GI diseases. So if we can turn now to the slides, I'm going to show you our experience in Italy. This is a nice paper, data from 121 hospitals in all 20 Italian regions. And you see from the color code that is here down on the right part of the slide, the light red is reduction around 30 to 60%, and dark red is more than 60% of endoscopy procedures in many regions, particularly those that were highly affected by COVID-19. And the northern part of Italy had this very important reduction in the procedures. And also ultrasounds, you see that most of the regions had more than 60% reduction. This is in a slight difference compared to the results that we got from the poll, because it seems from the results that the ultrasound procedures were considered more safe and were continued. In Italy, it was just the opposite. In the next slide, you see the shifts in GI clinical presentation due to COVID-19. Due to the fact that we managed mainly urgent endocrinology patients in most hospitals which were involved in COVID-19 and the reduction of routine activities, then unfortunately we had a delayed management of patients, probably a delayed cancer screening and delayed follow-ups. And this raises the question on whether we will see in the future also higher mortality, higher morbidity of diseases, reduced responses to treatment, and also if we see during the COVID-19 pandemic a more severe presentation of cases. In the next slide, you see what happened in the United States. We have data from America, probably a similar figure we have also in Europe. These are weekly screenings for major cancers, breast cancer, colon cancer, and cervical cancer. And as you can see, they had a dramatic drop in the number of screenings, more than 90% fall in the screening, for example, for colonic cancer. And we think that this will have an impact in the future in cancer, colonic cancer, and also other GI cancers. And in this slide, you see a paper that has been recently published by surgeons that looked over the years at what happens if we delay surgery in patients for GI cancers. For gastric cancer, a delay of more than 30 days seems that has no impact on the survival. However, a delay between 30 days and 8 weeks for pancreatic cancer, colon cancer, and rectal cancer has an impact on survival. So if we delayed these surgeries in our departments due to COVID-19, probably we expect to have a reduced survival in our patients. Now, moving to another topic that is psychological consequences of COVID-19. we think that there will be an impact on clinical presentations. We know from the literature that catastrophic events, and certainly we can consider COVID-19 a catastrophic event, may lead to a number of different consequences on our patients, but not only on our patients, but also on healthcare providers and the families. And one of these consequences could be post-traumatic stress disorders, which is flashbacks, nightmares, increased arousals, and reduced social life. With severe cases of COVID-19, we had more hospitalization, patients admitted to ICU, intensive treatments, physical and psychological stress. This is no matter. And what we expect in the future, this is only an hypothesis, but is very likely, is that this will have long-term consequences. It's interesting that the same Italian study that I showed you before, looking at the reduction of endoscopies and ultrasound, the Italian group looked at the impact of stress on the physician on the left. You see stress measured on a scale from 0 to 10. 0 no stress, 10 is the highest stress ever perceived by the patient or by the physicians. Most of the physicians had a high, very high stress level. But this was also reflected on a high stress level on the families of the physicians, which is very important because at least in Italy, this is our experience, many physicians were worried, and their families as well, of getting infections of their kids, of their spouses, and transmitting the infection. And as a matter of fact, particularly in northern Italy, some physicians stayed in the hospital and didn't go home for a long period of time. So this is very interesting. Another point is the long-term impacts of the infection on the gastrointestinal tract. As you know, SARS-CoV-2 viruses can infect the gastrointestinal tract. The infection can be transmitted by the oral fecal route, and the infection in the gut can lead to inflammation. This has been demonstrated, for example, with increased calprotectin levels in patients infected with SARS-CoV-2. And the hypothesis is that a severe infection of the gut can lead to consequences, particularly in the development of IBS and other functional GI disorders when the infection finishes. And this is a paradigm that has been nicely demonstrated in post-infection IBS with the Campylobacter, Shigella, Salmonella, and other pathogens, including viruses, for example. So this is something that we probably will expect in the future, a wave of increased functional GI disorders in patients infected with COVID-19 infection. So here you see a list of papers that were mentioned during this brief presentation. You can see this later on if you look at the slides again. Now we move to the next topic, which is organization of research. And again, we have a few questions for you. If we can pull question number 20, I think, yes. My research has been substantially delayed due to COVID-19. Let's vote. This is obviously true for the hospitals that were involved in the management of these patients, in my hospital for sure, even if you see the results. I think that we can pull the, okay. Most of the people attending this webinar say that, yes, there was an impact. In my hospital, this was obviously a downside of the infection, but also an opportunity to start studies directed towards understanding better COVID-19 infection. And as a matter of fact, yesterday I participated in a webinar from our university, and more than 120 papers on COVID-19 were presented by our university in this period. So it has been a good, also good opportunity for researchers to study COVID-19. In the next question, which is number 21, we would like to ask you if studies focused on COVID-19 are of lower quality compared to pre-COVID-19 studies. So we had to rush, we had to study this infection, we had to present our protocols to our ethics committees quickly, quick approval, we had to rush, and we wonder whether this impacted on the quality of this research. And the answer is half and half. So we will see the results of a paper that has been published on this later on. Now we have the next question, which is question number 22. Do you think that we need more funds dedicated to COVID-19 studies? Let's see the answer. Well, this was an easy question. Everybody thinks, particularly those involved in research, that we never have enough funds. So, as a matter of fact, 9 out of 10 people think that we need more funds. Next question is number 23, which is similar. Due to COVID-19, we need more funds to support research in general, not for COVID-19 studies. Well, easy. More than 90% of you think that we need more funds. So if we can start again with the slides. We have a few.
Sorry, we have only like 4 minutes.
Okay, I will go quickly on this. We should assure that there is safety for the patients and staff involved in research. We should design high quality research protocols, of course. And in the next slide, I would like to raise the point that probably we have to modify the way we conduct research and use more telemedicine, telephonic interviews. We should also eventually terminate the trials earlier. We should modify the way we conduct research in this period, and obviously acknowledge everything to our ethics. All the papers that were published in clinicaltrials.gov, more than 586 of these protocols, 60 many had a small sample size, low evidence of completion, delayed recognition of effective therapies, and waste of time and resources. I think that this research, due to the fact that we had to rush, was not as good as we hoped. So I think that we have to consider this literature very carefully when we read it. Last point I would like to raise is related to funds and to initiatives that have been raised during this period by several societies, including UEG. Here you can see a list of these initiatives, and I think that these initiatives need to be supported by governments and national and European investments. I think that this is very important. One initiative, I take this last minute to promote this study because This was promoted by our university in collaboration with the UEG and ESNM, which is the European Society of Neurogastroenterology and Motility. This is a very active and important study. We recruited more than 1,000 patients to look at GI symptoms during COVID infection and the effects in the long term of these infections. You can participate if you go through the web page of UEG. You can also find this initiative and participate if you are interested. Again, some papers you can look in the slides related to this last part of the presentation.
Okay, thank you very much, Giovanni. Thank you very much, Heinz. I think we covered a lot of things, very interesting to get the feedback from our colleagues from other parts of Europe. I think the time is now over, but since we had some problems with the connection, I would suggest that we might take 5 or 10 minutes more to answer some of the questions and maybe discuss some of the issues, if it's okay with you. If any of the participants have to go, then we wanted to thank you very much for their time and for the patience and for the feedback today. There was especially a question about the endoscopy suite. I mean, how are you in practice organizing the endoscopy, elective endoscopy nowadays? I mean, what kind of protocol you use? How do you select the patients? Are you testing in advance? Are you not testing? What's your take on that?
Yeah, we are. I have summarized, and there was a question on the endoscopy precautions. You're referring to that. I have summarized testing the patients before they come to endoscopy, but we treat every patient as being potentially infectious. So for all endoscopic procedures, we are still wearing personal protective equipment with gowns, with a FFP2 mask, with a head cover, and with a double glove. Independent, and we do not look for COVID testing before that. And we are currently now with the usual usual endoscopy procedures and with the usual indications. So there is currently now no change in accepting patients as to before the COVID epidemic. But as I remind you that we are now in a very quiet phase with regard to COVID already.
Okay. Do you, Giovanni, do you use the same equipment independently of the risk of the patients, or do you reserve some type of masks or, for example, double gloves to some special patients? What's your practice?
We wear the same protective equipment for all the patients: double gloves, double mask, FP2, plus the surgical mask. And we train, at least we make a telephonic triage before admitting the patients at the endoscopy, asking for fever and contacts, and then the patient is admitted to the endoscopy after we take the temperature of the patient, and then we start the procedure.
Okay. So related to endoscopy in a way, and also on the delay of probably the diagnosis of cancers, what's the status of colon cancer screening right now in your places? And if it's not running, what is the plan to move forward with it in the fall, if the circumstances permit to restart it?
We have started again since I would say 3 weeks ago with at least colon cancer screening, and unfortunately we have a long waiting list, so there will be definitely a delay in the screening. However, we started again, and we hope we can save time during the summer. Unfortunately, the time that we have to dedicate to each endoscopy is longer now, because we have to prepare the patient, we have to wear the PPEs, and then we have to disinfect the endoscopy room after each patient. So that takes a little bit longer time, and we have to reduce the number of patients in the waiting rooms and also in the endoscopy suite. So this unfortunately reduced the rate of endoscopy that we can run each day in our unit. So the waiting list, which was long before, probably cannot be shortened during this period.
Yeah. This is exactly as it happens in Graz, what Giovanni just said. It just takes longer now to perform an endoscopy, and we cannot do as many endoscopies now in the time available for both reasons. The endoscopies take longer, and the waiting rooms, the waiting areas are limited with the number of patients, so that sometimes we have to wait for patients to come. In previous times, the patients would have waited for us. Now we are sometimes waiting for the patients. That's also bad.
Yeah.
Right. Related to stress, because I think it's a problem that I'm very happy that you brought it, Giovanni, because I think it's an underlooked issue, especially in healthcare workers, like young nurses that had to deal with very catastrophic situations, people not resting and extra shifts. How first, Heinz, how did it impact the situation in the stress levels? I know it might be a subjective feeling in the endoscopy in the medical areas in Austria, and also for both of you, how do you think that we should address that? I mean, do we need to start programs, and do we need to ask for this thing, both in health takers and in healthcare givers, and also in patients? How should we address that in the future? Because the consequences of this are probably going to come in some months, like you addressed.
The stress levels were very different in different areas of medical care. In fact, in some areas which were closed down to have reserve capacity for COVID care, in fact, people worked very little and were waiting for patients which never did turn up. And whereas in other areas, like emergency care, where with shifts and with extra shifts, and for example on COVID wards, stress level was pretty high, with a high number of patients coming through, with fast decisions having to be made, with new clinical challenges, us being mainly gastroenterologists and hepatologists now having to take care of general internal medicine, because those patients who were suspected of having COVID, they had all kinds of diseases and fever. Many of those did not have then COVID, but we had to coordinate care in these patients. So stress levels were very high. I think it is very important. One shall not look back and say this was done wrong or not, and shall not judge the history from what we know today. But we shall learn from history, and I think that is the challenge in the upcoming weeks and months, that we shall take the time of quietness, if it's already becoming quiet in different areas like in ours. Choose this time of quietness to think about what we have done during the COVID high times, and what we can learn from that, because next COVID will come.
I think that there are two aspects that I could see in terms of psychological impact of the infection in healthcare providers. On one hand, we witness the need of healthcare providers to be helpful in a way, and I've never seen in my entire career such a need to be helpful for our patients. And all the staff was so compact, and everybody was trying to help in a way. So everybody was doing very hard and long shifts and worked very hard in that period. On the other hand, there were burnouts. There were particularly young people that were very stressed because they thought they were unprepared to manage these patients. They were also unprepared to recognize when the patients became critically ill and decide when to send them to the ICU, how to monitor them, how to manage the situation. So I think that on one hand, there was a lot of cooperation of the healthcare providers. On the other hand, there was a lot of stress.
Right. I think we have time for one more question, which I think is a hot topic also, and Heinz showed it when people answer the questions about telemedicine, how much that has increased and it's going to be implemented in our clinics. And I wanted to ask you, of course, you use telemedicine now. How do you use it? I mean, do you use the telephone? Do you use video consultations? And if you see the possibility for some of these apps, for example, to get information about specific, because there are some available now, for example, for IBD that I'm aware of that have been shown to be cost effective. What are you using, and how you see the future of how we're going to use telemedicine in the next month or years? And we will wrap up with that.
Yeah, I think the COVID time has shown us that we sometimes steal time of patients by having them attend our clinics, asking them to travel an hour or two to see us for 20 minutes and then travel back for another hour or two. So we are time stealers, time robbers. We have been in the past, and we have identified now situations. We have been obliged to identify situations where we do not have to steal patient time, but to be responsible and do online medical services. And it really functions well in other countries for certain situations, like Australia, like I think Sweden. And what technique to use depends on the clinical situations. In GI patients, it is mostly using the telephone, whereas my dermatology colleagues use videos and photographs. So it depends very, very much on the clinical situation. However, what we do not yet have in Austria is acceptance by the payers of medical care. So how the future will develop in acceptance of hospital administrations and health insurance companies, we will see how that develops.
Yeah, I know that there is current working in regulating that. Actually, it's in the regulations too for telemedicine in several countries. At least in Norway is the case.
Mm-hmm.
Yeah.
Another aspect that I think is important, that while telemedicine works well in younger patients, particularly in older patients and severely ill patients, obviously cannot be managed, and many older patients with dementia and other problems is obviously difficult to manage the visit in this way. So I think that family physicians and the territory around us should do this type of work, because it's very difficult to manage this type of situations with telemedicine.
Okay. So with that, I want to thank you very much for overcoming the technical issues, for your patience, for your expertise, for taking the time now in the summer to illustrate us with that. I think the discussion was really interesting. I would really look forward to meet again in 6 months or a year and see how everything turned out, if there's a second wave or not, how things are actually changing. So that would be very interesting. And thanks everybody for your patience. I encourage you to go to to the UEG page. There you have a lot of content. This webinar will be available, I guess, soon. So it would be a possibility to check it. And again, thank you very much. And thanks to UEG for the opportunity to moderate this session. Thank you very much, Giovanni and Hayes.
Thank you. Bye.
Thank you. Bye.